chairing the session, yeah. I'm chairing the session.
Okay, there's a slide advancer there?
No, he is presenting.
Okay.
Paulo?
Paulo, hi. So there's a slide advancer there? Okay. But I don't know if you're gonna stand up there or you can do what you want. Yeah, right here, so it's just forward.
Okay.
Easy, and there's a timer here.
Oh, that's good.
Mhm.
That's good. The rhythm.
You start in a minute, so.
We'll give it a couple extra minutes.
No,
Let's-
I'll start the timer at 1:30, because your block is from 1:30.
Okay, that's okay.
Do we have virtual?
Not for this session.
No. So that means he can ask only one question of you. And there's another gentleman that he will ask you one.
What time are you going to have dinner tonight?
Are you starting the timer? I think it's 2 minutes past, so good afternoon. The topic for the next 20 minutes is liver resection in the era of NAFLD. Now this was, I was remembering this association's meeting in Edinburgh in 2006 when the then president gave a plenary on fatty liver disease, and everybody wondered why we have this topic discussed among surgeons. It's a hepatology disease. But now, so many years later, we know how relevant it is, especially in case of transplant selections, and as a cause of liver disease as well. So it's my great pleasure to introduce the speaker, Professor Paulo Herman. He is the head of liver surgery unit in Sao Paulo, and he's going to take us through, I would just add, safe liver resection in the era of NAFLD. So, please, Paulo.
Thank you, Mr. Chairman. Good afternoon. We're going to talk a little bit about a subject that doesn't look very surgical, but in a world where we have an epidemic of obesity and metabolic syndrome, and this has a huge impact on liver resection, especially major liver resections, this is a very important subject in our day-by-day practice. Over the last 2 decades, the prevalence of metabolic syndrome has reached, as I said before, endemic proportions. In the Western countries, in Europe, about 25% of the population present the metabolic syndrome, and in US, 1/3 of the population. And if you look here in this country, the population older than 60 years, we have almost 50% with people with metabolic syndrome. So it's a huge endemic situation. The non-alcoholic fatty liver disease is the hepatic manifestation of metabolic syndrome. And when we talk about non-alcoholic fatty liver disease, we're talking about steatosis. That's not so important for the surgeon, but steatohepatitis that has a huge impact on results of liver resection, and of course, advanced disease with irreversible damage to the liver, leading to liver cirrhosis. How do we define the metabolic syndrome? We need to have at least 3 of those 5 criteria. So obesity or increased abdominal circumference, dyslipidemias, hypertension, and diabetes. 3 of those things, of those comorbidities characterize the metabolic syndrome. The metabolic syndrome is present in 1/3 of patients with non-alcoholic fatty liver disease, but when we look at those patients that are clinically relevant for us surgeons, that have NASH, non-alcoholic steatohepatitis, that impact liver resection results, 88% of the patients with NASH have the metabolic syndrome. So it's important to identify the presence of metabolic syndrome in patients submitted to liver resection because they for sure have advanced histologic injury, and they had a raised risk of morbidity and even mortality following liver resection. Most of the mortality are from cardiovascular complications. Let's talk about the non-alcoholic fatty liver disease relation with neoplastic diseases, what interests we, the surgeons. So let's talk about about colorectal liver metastasis. The prevalence of steatosis or steatohepatitis in patients with colorectal liver mets is much higher than metabolic syndrome. Almost 50% of our patients present steatosis or steatohepatitis. First, because most of our patients are overweight or present obesity. And second, because irinotecan-based chemotherapy is used in most schemes of neoadjuvant chemotherapy before liver resection. Non-alcoholic fatty liver disease is also is an etiological factor for hepatocellular carcinoma and intrahepatic cholangiocarcinoma, as we're going to talk a little bit later. There is a new definition of non-alcoholic fatty liver disease. There is a little confusion when you look at the literature in non-alcoholic fatty liver disease, metabolic syndrome, and metabolic dysfunction associated fatty liver disease, which means non-alcoholic fatty liver disease in metabolic syndrome patients. So there is a new criteria, and this criteria is based on the presence of steatosis, overweight or obesity, diabetes, and two of these 7 or 8 comorbidity items as higher blood pressure, higher levels of C protein, and higher levels of glucose, and dyslipidemias. So we can call, in these patients with metabolic syndrome, the metabolic association fatty liver disease, and not anymore NAFLD. When we look at the impact of NASH or steatohepatitis in our patients, this is an experimental study from a Japanese group showing that when you perform a liver resection in mice, in the first line, you can see the mortality of the rats when you do a 70% liver resection in a normal liver. But when we do a 30% in a NASH liver, it's a little bit, the results are a little bit lower. And if you perform a resection, in a 70% resection, in a 70% hepatectomy in a patient with NASH, you have a very, very worse result, showing that there is a direct reduction in liver regeneration and cell proliferation in patients with non-alcoholic steatohepatitis. So this can show experimentally the clinical importance of steatohepatitis in the setting of a major liver resection. This is a very recent meta-analysis published this year with 15 comparative studies on the impact of metabolic syndrome and long-term results, and short and long-term results following liver resection. We have more overall complications, more major complications. However, when we look at the oncological results, there is no difference in overall or disease-free survival. So what do we see when we look in a huge series with patients with NASH? More complications, especially hemorrhage or infections. We don't find a statistically significant difference regarding liver non-function. However, if the patient has a proven steatohepatitis with ballooning, with fibrosis, we have liver non-function, we have liver insufficiency at the postoperative period. So it is a quite important risk factor. However, as I said before, there is no difference regarding the oncological point of view. They present the same overall and disease-free survival. This is a study here in the US with the NAFLD, where they looked at liver resection in patients with high BMI, more than 30, and metabolic syndrome, hypertension and diabetes. And what did they find? They find a higher number of complications, exactly as in the experimental setting, greater risk of reintubation and ventilator dependence, more blood transfusions, more myocardial complications, and more infections. And metabolic syndrome was directly related with the increased risk of postoperative death. This is really an important subject for us surgeons. Another subject very important is the relationship of non-alcoholic fatty liver disease in the context of colorectal liver metastasis, because we can cause steatohepatitis using chemotherapeutic drugs. We call it chemotherapy-associated steatohepatitis, known as CASH. This is a CT scan of a patient who received, with a huge metastasis, who received irinotecan in his irinotecan-based chemotherapy, and you can see what happened with the liver parenchyma. So it is quite important to understand what's happening with this patient, because if you do a major liver resection, this patient is at risk. We know that hepatic steatosis, that is a mild manifestation of non-alcoholic fatty liver disease, may occur after the treatment with 5-FU, that makes part of the majority of chemotherapy schemes that the oncologists used to do. But most importantly, NASH, that is a serious complication of non-alcoholic steatohepatitis, may occur after the treatment with irinotecan, as I showed you in the last slides, especially in obese patients. So if you have an obese patient, you have to avoid the use of irinotecan, because you deal with an important steatohepatitis, and this can increase the risk of a major liver resection. Irinotecan-associated steatohepatitis, as I said, can increase morbidity and even mortality after hepatectomy. So when we have a patient who had that was submitted to a long-term preoperative chemotherapy, especially with irinotecan, if this patient is obese, we have to leave at least 30% of liver remnant. We try to do it to leave near 40%. We have to treat those patients as they present chronic liver disease. This is the only way to lower the morbid mortality that these patients can present at the perioperative course. Non-alcoholic fatty liver disease is also associated with hepatocellular carcinoma, and I can tell you that in most countries, in this country as well, the most important etiological factor for hepatocellular carcinoma is steatohepatitis. You see in orange an increase of cases of hepatocellular carcinoma due to NAFLDs. What can we find when we look at patients with non-alcoholic steatohepatitis and liver resection? We have an increase in complication rates, including liver failure, postoperative liver failure, and moreover, mortality. There is an increase in 30-day mortality rates. But especially when you compare non-alcoholic fatty liver disease, HCC, with other kinds of HCCs. So despite the liver function remains preserved in most patients with non-alcoholic liver disease, you have more postoperative complication, and you have a higher index of a higher rate of mortality. When we compare resection in patients with non-alcoholic fatty liver disease, HCC, and patients with other types of HCC non-related to non-alcoholic fatty liver disease, in an oncological point of view, results are the same. So you don't have a long-term impact in survival. However, you have an impact in perioperative results. When you look at most of the criteria of HCC resection, they are in patients with cirrhosis and a well-defined clinical situation. Non-clinical portal hypertension, early stage HCC, good performance, preserved liver function. However, most of these patients who present HCC and non-alcoholic fatty liver disease, they don't present cirrhosis. So all these guidelines like BCLC, they're not appropriate for patients with non-alcoholic fatty liver disease. And there is no guideline for those kind of patients. Those patients, as I said, they present more advanced disease. When you do the diagnosis of HCC in a patient with non-alcoholic fatty liver disease, 70% of those patients present advanced disease, 70%. That's why we don't, probably because we don't have surveillance programs for patients with non-alcoholic fatty liver disease, differently from patients with Hep C or Hep B. So those patients have an increased risk of perioperative complications. The third neoplasia related to non-alcoholic fatty liver disease is cholangiocarcinoma. It is metabolic syndrome present in those patients. It's related, is an etiological factor for cholangiocarcinoma, and is also related with postoperative major complications. It is an independent risk factor for major complications as infection, hemorrhage, and cardiorespiratory complications. However, as for HCC and as for metastasis, if you look in an oncological point of view, no impact is found regarding survival or disease-free survival. How to diagnose? I told you how to do a clinical diagnosis with all those comorbidities. But should we do biopsy? I think I can tell you that 15 years ago, maybe 10 years ago, we used to make a lot of biopsy on those patients, especially before major liver resections. And there was a very nice score telling us how the steatohepatitis could impact liver histology. So in this score, we have 8 points. If you have a score 3 or more points, there is a higher risk of major complications following liver resection. However, nowadays we don't biopsy anymore those patients because our image armamentarium has improved a lot. So nowadays we use MRIs, and at MRI you can detect severe steatosis, CASH. We can measure fat fraction, fibrosis, and we can see signs of portal hypertension. So the MRI can give you all the information that this patient is at risk. We also can have some functional information about those patients using hepatobiliary specific contrasts. Regarding this contrast, as I told you, you can do a morphological and functional evaluation of the liver at MRI. You can distinguish between the two subgroups, the light subgroup of non-alcoholic fatty liver disease, that's steatosis, that doesn't matter for resection, but the risk group for the group with non-alcoholic steatohepatitis. And also, we can stage fibrosis. We can do an MRI elastography of those patients. We don't need those machines that the hepatologists use to employ the elastogram. With the MRI, you can do a good elastography. So you can have a risk assessment of liver failure for major liver resections performing a good MRI. When we have a metabolic syndrome, what means this patient is at risk? We have an increased insulin resistance, a pro-inflammatory state, a prothrombotic state, what means that you have a raised perioperative complication rate and high mortality rates following liver resection. How we deal with those patients? We can use insulin sensitizer, antioxidants like vitamin E or vitamin C, dietary change, physical activity, weight loss. However, all these clinical steps that I told you need time to do. If you put a patient on exercise, on diet, and you want him to lose weight, this will take 1, 2, 3, 4 months. However, when you're dealing with patients with hepatocellular carcinoma, colorectal liver metastasis, or cholangiocarcinoma, we're not able to wait 2, 3, 4 months. And in a practical point of view, it's quite difficult to improve patients' conditions. This is important for a patient who eventually is going to donate his right lobe in a living donor program. So you can put this patient on a program of diet, exercise, and use antioxidant drugs and insulin sensitizers. So maybe for a living donor, but for an oncological patient, this is, in a practical point of view, as I said, not possible. Of course, we can quickly control diabetes and blood pressure. This we can do in 1 or 2 weeks. So those patients that have controlled diabetes, controlled hypertension, they present a better postoperative outcome when they have metabolic syndrome. However, we don't know the benefits of all these steps if the patient has chemotherapy-associated steatohepatitis. So losing weight, we don't know if this has any impact in patients with CASH. We know that this has impact in metabolic syndrome patients. What can we do in a practical point of view? Parenchymal-sparing techniques that we know that oncologically they have the same results of taking a huge part of the liver. Like in this case, with 12 metastases, we did 12 wedge resection preserving parenchyma. Or in this case, with a tumor that responded to chemotherapy, but it was attached to the right hepatic vein, invading the middle hepatic vein, and close to the left hepatic vein. We do what Professor Torzilli called the tunnel, liver tunnel, preserve liver parenchyma, instead of doing a right trisegmentectomy. So we have to try to preserve liver parenchyma. The other important point that we can act is to modulate liver remnant volume. So we can use the classic selective portal vein embolization, like in the CT scan, or using ALPS, venous deprivation, radioembolization. But as I said before, we need a 30%, or in cases in obese patients with long-term chemotherapy, 40% of liver remnant volume. So, NAFLD has become the leading cause of chronic liver disease worldwide, with increased perioperative risk, morbidity, and mortality, no impact on long-term survival, and we need a careful surgical evaluation and planning. Diabetes and hypertension control, dietary changes in exercise if you have time, meticulous cardiovascular evaluation, liver remnant volume evaluation, MRI, the best way to stratify those patients, biopsy if you have any doubt. We need to do as much as it's possible, short-term neoadjuvant chemotherapy. We have to take care with irinotecan, especially when patients are obese. We always have to try to do parenchyma-sparing resections with or without remnant liver modulation, liver volume modulation. And in those patients who had a long-term preoperative chemotherapy, who is going to be submitted to a major resection, probably we need 40% of liver remnant. Thank you very much.
Thank you, Dr. Herman. We have 5 minutes for questions, so anybody with pressing questions, please put up your hands. Yes.
That was a wonderful presentation. Thank you very much. Julian from Melbourne, Australia. Have you had an experience in using OptiFast or calorie restriction in this group of patients?
In our group, we don't do living donors. But in the group in our hospital, they are used to do living donors, and you have obese potential donors. They have a protocol to use specific diets and protein-based diets and exercise. As we deal with oncological patients, we don't have time enough to wait for those patients to present weight loss, so we don't use it routinely. We change patients' diet because we need a diabetes control, and we try to take them to resection as soon as we can, of course. Thank you.
Any more questions for Dr. Herman? We still have time. I think you have answered all the questions.
Oh, yeah. Okay.
You want to make a comment? Oh, there is one question.
Paulo, thanks. Great. So you do a lot of laparoscopic liver surgery, and sometimes these patients are terrible in the OR. Yeah. They bleed from everywhere. Sometimes the usual tricks don't work. Do you have any advice for us to how to handle problems in the OR with these NASH patients? How, like anesthesiologists, any smart approaches?
Yeah, it's quite a challenge to operate those patients, and as I said, we don't have time enough to make them lose weight, so it's quite complicated. We do Pringle maneuvers in a routine as a routine in those patients, for sure, because they bleed more than the other patients. We try to slow our movements. This is an interesting tip, because as you get experienced, you get faster. And for patients who are obese and who have a very fragile parenchyma, you have to go very slowly, very slowly. So we work in a slow motion in this kind of patients. We can do much more than this. Low CVP as for any patient, so I think there's no other tips.
Thanks.
Do you do anything different?
No, sometimes these patients seem to be paradox also, so we lower the CVP and then they bleed more. I think some of them need more filling, more preload to have a good emptying of the liver somehow. So but they confuse me. Really, we need to figure out a way to do this better.
It is quite difficult.
Yeah.
I have an advice for you that when you have a patient that you're going to do a major liver resection and you have doubt if you should or not embolize, you should embolize. I think the most important message of this lecture probably is this. Should we embolize this patient? This patient has 32% of liver. If you're thinking if you should embolize, do it. Because those patients, you will regret if you do not embolize. So I think this is a good message from this lecture.
Do you use shorter Pringle time? Do you use 10 minutes or do you do 15 minutes in these patients?
We usually do 15-5, 15-5. Yeah.
Thank you. I think we have to close the session and hand over to the next team. So thank you very much, Dr. Herman. It was a pleasure. Nice to see you.
A lot of people.
That's good.
Are the speakers here? We'll just wait for some time. Afternoon, gentlemen. I am Dr. Jagannath, and with me in co-chair is my good friend Javier Arexpella from Chile. We just want to know whether the presenters are all here. Shraddha Patkar, Hiromichi Ito, Saneya, Maitam. Great. Do we have any virtual presentations on this? Audio AV team? Anything? Shraddha Patkar is here? No? Yes, we have Patkar coming up? Yes. Yeah, okay. She's going to be on live or just a video? They're in the Zoom now. Okay. So it's a pleasure to introduce the first speaker, Shraddha Patkar from India. She's one of our very bright HPB surgeons who is in the Tata Memorial Hospital, doing a lot of work on gallbladder and gallbladder malignancies. So Shraddha, please join us over the video link and present the first paper on the consecutive surgeries for gallbladder cancer in the era of multimodal treatment, lessons learned and way forward. Yes, Shraddha, good to see you. Please go ahead.
Yes, sir. Can my presentation be shared?
They're going to present it from here. Oh, yeah, okay.
I'm not able to see it.
You're not able to see it. Just give us a minute. It's quite late in the night, I know that. Very late, yes. Can she share the presentation from the Zoom? It's easier for her. No. Okay. Yeah, sure.
Okay,
Yeah, Shraddha, you need to bear with that we'll show the presentation, and as you're getting the flow, you can just go ahead. Yeah, go ahead. No, this is not the one. This is not hers. Can she stream from her on Zoom link? Yeah. Your presentation is on, Shraddha. Go ahead. Yeah, we can start the slides. You're on, Shraddha. You asked for the next slide. You're on.
I'm not able to see the presentation.
No, you won't be able to see the presentation, but you ask for the next slide and you follow the track.
Okay.
Yeah. This is, okay. Yeah.
Good afternoon, everyone. We do not have any financial or
No, see, you're getting the wrong presentation. This is Sanaya. This is Shraddha, yes.
gallbladder cancers.
Yeah.
I have no disclosures to make. As we all know, gallbladder cancer is the most common biliary tract malignancy. Despite surgery, the 5-year survival continues to be dismal. Geographical disparity in distribution predates the lack of evidence-based management disease protocols. We analyzed our institutional database of over 1,300 consecutive surgeries performed for gallbladder cancer at a high-volume tertiary care center. It was a retrospective analysis of a prospectively maintained database from Jan 2010 to December 2019. Demographic, clinico-radiological, and surgical details were recorded. The primary objective was to analyze the survival outcomes, with the secondary objectives being to study the impact of perioperative systemic therapy on outcomes for locally advanced gallbladder cancers, as well as to identify prognostic factors for survival. All patients who underwent surgery with a preoperative diagnosis or a suspicion of malignancy were included. These also included incidental gallbladder cancer, progression after neoadjuvant therapy, and those patients who were not offered surgery, as well as patients with a benign diagnosis on histopathology were excluded from on analysis. A radical cholecystectomy was performed in cases of malignancy confirmed on intraoperative frozen section. It was used to guide the extent of surgery, assess interaortoquable nodal station, as well as the margin of the cystic duct. Patients with confirmed metastasis on frozen were not offered radical surgery. Incidental gallbladder cancer were first restaged using a CT or a PET scan, depending on the time of presentation after index surgery. If non-metastatic, patients who had T1B or above disease were offered revision, irrespective of the time of presentation. Locally advanced gallbladder cancer were included as per predefined TMH criteria for high-risk gallbladder cancers, which included clinically T3, T4 disease, with node positive or obstructive jaundice and vascular involvement less than 180 degrees. These patients were preferentially chosen for neoadjuvant therapy after a positive tissue diagnosis. Patients of incidental gallbladder cancer without any residual disease were first offered upfront revision surgery, whereas those with any residual disease in the gallbladder fossa or periportal nodes warranted neoadjuvant treatment. This consort diagram depicts the results of 1,307 patients undergoing surgery. Of this, 267 patients were benign. Finally, 1,040 patients had a proven diagnosis of gallbladder cancer, of which over 50% were incidentally diagnosed. The inoperability rate was close to 20% despite the best imaging modalities available. The demographic parameters of patients undergoing upfront as well as neoadjuvant therapy is depicted in this table. Jaundice at presentation was seen in around 10% of the patients necessitating a preoperative biliary drainage. Complications as per the Clavin-Dindo scale were acceptable, and margin positivity rate was less than 5%. In context of multimodality treatment, around a third of patients received neoadjuvant therapy, of which mainly chemotherapy was administered to 27%, whereas less than 5% received chemoradiation as a part of an ongoing randomized controlled trial at the institution. Over 50% of the patients received adjuvant therapy for disease which was T2 above and node positive. These patients usually receive chemotherapy alone, with 2% patients receiving chemoradiation in view of margin positive resection. The median follow-up of the entire cohort was 30 months, with an overall survival of 44% and a disease-free survival of 37%. Stage-wide survival analysis revealed an excellent survival of over 90% for stage 1 disease that dramatically dropped to less than 10% for stage 4 disease. Analysis of the recurrence pattern suggested that most of the patients had distant site recurrence, with only 6% having locoregional disease. 4% of the patients had recurrence at both distant and locoregional site. Less than 2% were classified as having oligometastatic recurrence, and few of these were offered curative resection. N2 nodal stage and involvement of the liver wedge by tumor predicted increased rates of distant metastasis. Survival of patients who could undergo radical resection after chemotherapy was superior in both terms of both OS and DFS as compared to patients who were inoperable. Advanced nodal stage, advanced T stage, nodal positivity, and poorly differentiated grade were associated with inferior survival on multivariate analysis, which held true for overall as well as disease-free survival. Management of poor primum gallbladder cancer depends on the stage of presentation. Patients with non-metastatic early disease should undergo surgery. It is prudent to offer systemic therapy first to patients with locally advanced cancer. Multivariate analysis in the current study showed that survival outcomes are dependent on the stage as well as grade of tumor, reflective of the inherent aggressive disease biology. Chemotherapy in the neoadjuvant setting helps in selection of patients with favorable disease biology to undergo curative resection, and these patients who can undergo curative surgery have a superior outcome compared to those with inoperable disease. The locally advanced gallbladder cancers in the current study had an overall survival of 50% at 3 years and 38% at 5 years, which compares favorably with the available world literature. The strength of the study stems from it being the largest single-center audit of surgery done for gallbladder cancer, especially from a high endemic region. Uniform disease management practices were practiced across the cohort. The retrospective nature of the study limits its generalization, as well as the selection bias for patients receiving neoadjuvant therapy in early part of the study. However, we can conclude that inherent aggressive tumor biology, along with the stage of the disease at presentation, are the chief determinants of survival outcomes in gallbladder cancer. Multimodality treatment is the way forward to improving outcomes in locally advanced gallbladder cancer, as it helps select patients with favorable disease biology for radical surgery. However, randomized evidence is needed to emphatically establish the role of systemic therapy in neoadjuvant setting for these patients. Thank you.
Thank you for your presentation. I would like to ask two things. First, what is the schema you give for the neoadjuvant therapy? What kind of drugs are you giving to the patients? And what is the selection do you do? How do you select the patients who will receive neoadjuvant therapy?
Initially, the criteria which we used for selection were any patient who had liver infiltration or had node-positive disease or had vascular abutment or obstructive jaundice. These patients were initially staged with a PET scan, and if found to be non-metastatic, we included them for neoadjuvant treatment protocol. The chemotherapy drugs which are mainly used are either gemcitabine cisplatin or oxaliplatin. We also have an ongoing randomized trial at our institution where they are randomized to neoadjuvant chemotherapy or chemoradiation. In the chemoradiation arm, the patient usually gets capecitabine with RT, followed by 2 cycles of gemcitabine and cisplatin, following which they are assessed for surgery. The median duration of cycles is usually 3 to 4.
Thank you.
Thank you, Shraddha, for this nice presentation and the great work. We move to the next paper. That's from the prediction of lymph node metastasis, which is very important for early gallbladder cancer. And this is from Japan. Dr. Ito. This is also by Zoom link. This is going to take time on. Yeah, okay. There you
I
are.
have no financial interest to be disclosed. Early gallbladder cancer is often incidentally discovered with cholecystectomy for presumed benign disease. Predictor for possible residual disease is poorly defined except for the tumor depths, and thus additional surgery, including lymphadenectomy around the hepatoduodenal ligament and resection of the liver at the gallbladder flutter, is currently recommended for all patients except for those with a mucosal tumor PT1A. We conducted this study with 2 study aims. 1, to evaluate histopathologic features associated with risk of lymph node metastasis among PT1 or T2 gallbladder cancer. And 2, to identify low-risk group of patients who can spare additional operation after non-oncologic cholecystectomy. Among consecutive patients with gallbladder cancer who underwent radical resection from 2006 to 2020 in our centers, those with PT1 or T2 gallbladder cancer was identified and included. Pathologic features associated with nodal metastasis was assessed with chi-square test and logistic regression. Evaluated long-term outcomes were recurrence-free survival and overall survival. The total 79 patients were included in this study, and their demographics were shown. Unlike the other Western cities, most of our patients received oncologic radical resection after initial diagnosis, rather than incidental discovery with non-oncologic cholecystectomy. Most patients had PT2. The median 10 regional lymph nodes were removed, and the lymph node metastasis was found in 27% of patients. The pathologic characteristics of gallbladder cancer with nodal metastasis were compared with those without. 3 types of peritumoral microinvasion: lymphatic, venous, and perineural invasion were seen at much higher rate among those with nodal metastasis than those without. In multivariate logistic regression analysis, the lymphatic and perineural invasion remains significant risk factors associated with lymph node metastasis, with hazard rate 23 and 11, respectively. When the patients were divided into the three groups, 1. No risk factors present, 2. Only either one present, and 3. Both two present, the risk of lymph node metastasis was well stratified as shown. In the group with both lymphatic and lymphatic perineural invasions, 100% had lymph node metastasis, whereas only 6% had lymph node metastasis in the group without any invasion. Finally, the impact of microinvasion on the long-term outcomes was assessed. As expected, both recurrence-free survival and overall survival are also well stratified according to the lymphatic and the perineural invasions. In summary, the lymph node metastasis was seen in more than a quarter of T1, T2 gallbladder cancer, and thus, when it was diagnosed after an oncologic cholecystectomy, chance of residual disease is not neglectable. In these studies, we show that the peritumoral microinvasion, especially the lymphatic invasion and the perineural invasion, were reliable predictors for lymph node metastasis, and these factors can be used for the guide for the decision making for the additional surgery for incidentally discovered PT1 or T2 gallbladder cancer. Here are my conclusion. Peritumoral lymphatic and the neural invasion for early gallbladder cancer are associated with risk of lymph node metastasis and thus had a great impact on long-term outcomes. These pathologic features should be incorporated into the decision-making for additional operation for patients with incidentally discovered early gallbladder cancer. Thank you.
In the interest of time, we need to move to the next paper.
Yeah. Next paper came from India, from Professor Pandrawala, and is not positive in T1B gallbladder cancer, a happy human center experience.
Good afternoon, everyone. We do not have any financial or apparent conflict of interest. I'm Dr. Sania Pandrawala, HV Surgery Fellow at the Tata Memorial Hospital, and I'm going to present on node positivity rate in T1B gallbladder cancer at our institute. As we all know that gallbladder cancer is the most common biliary tract malignancy with the incidence as high as 10 to 22 per 1 lakh population in the northern parts of India. Since early gallbladder cancer has subtle imaging features, a high percentage of them is diagnosed as incidental gallbladder cancer, with almost 1/3 of them being PT1 stage. Lymph node metastasis is a known poor prognostic factor. However, we do not have any uniform consensus on radical cholecystectomy for T1B gallbladder cancer. So our aim was to analyze the lymph node positivity rate in T1B GBC operated at our institute and correlate it with long-term survival outcomes and recurrence rates. We conducted a retrospective review of a prospectively maintained database over the study duration of 11 years from March 2010 to March 2021. Our inclusion criteria were all patients of PT1B adenocarcinoma either upfront or incidentally diagnosed. Exclusion was any other histology, any other stage of disease or metastatic disease. All patients underwent a staging imaging investigation either in the form of a CECT thorax, abdomen, pelvis, if they presented as upfront or within 4 weeks of incidental GBC diagnosis, or a PET-CECT which was done after 4 weeks of surgery in order to avoid any post-surgical artifacts. The management plan was decided in a multidisciplinary clinic along with a radiation oncologist, medical oncologist, and a radiologist. Our institution protocol mandates a completion surgery or a radical cholecystectomy for all patients of more than equivalent to PT1B stage. We have given neoadjuvant chemotherapy principally in the form of gemcitabine and cisplatin for patients that had FDG-avid periportal nodes, which suggested lymph node metastasis in these patients. Our surgery, either radical or revision, comprised of a gallbladder or liver wedge, along with a complete periportal lymphadenectomy, including sections 8, 12, 13, and a cystic duct margin status, which was confirmed on frozen sections in the upfront surgery patients. Or if incidental patients did not have it in the prior surgery, then it was revised and sent in frozen section. Statistical analysis was done with SPSS version 28. Amongst the 1,245 patients over the 11-year study period that were operated for gallbladder pathology, 24% were stage 2, 37% were stage 3, and 88 patients were PT1, with 12 of T1A and 76 of T1B. Amongst the 76 patients, 11 underwent upfront surgery, 65 underwent completion surgery. 9 patients were given neoadjuvant chemotherapy due to uptake in periportal nodes, and these were excluded in our initial analysis. After excluding these patients, there were 67 patients of PT1B in our cohort, of which 7 patients had pathological node positivity, which amounted up to 10.4%. With a median follow-up of 47.5 months, this cohort of 67 patients had an OS and DFS of 89% and 86%. So our median age was 50 years, with most of the patients being women. Nodal age was 8. We divided the entire cohort of 76 patients into node negative and node positive cohort. The node positive cohort comprised those patients that received neoadjuvant chemotherapy due to uptake in periportal nodes or were pathological node positive. So these were 16 out of 76 patients, which led to the nodal positivity rate being as high as 21%. Our postoperative stay was 6 days. There was significant Clavin window morbidity was 5.2%, and there was no mortality. So when we compared the outcomes of node positive and node negative cohort, there was no disease in the liver wedge in final HPR in either of the cohort. Recurrence pattern was predominantly periportal or distant with no GB fossa recurrences. Node negative cohort had 8.3% recurrence and node positive had 43.7% recurrences. The survival outcomes after a median follow-up of 47.5 months revealed that the node positive cohort had an overall survival of 75% at 3 years as compared to 96.7% for the node negative cohort at 3 years. The DFS was 62.5% and 91.7% respectively. So we conclude that node positivity for T1B gallbladder cancer can be as high as 21%, which mandates a radical surgery with complete periportal lymphadenectomy to be considered as the standard of care. The interesting aspect that the predominant recurrence pattern was periportal or distant without any GB fossa recurrences or absence of any disease in the final HPR in the liver wedge probably suggests that a complete lymphadenectomy with avoiding a liver wedge could be the surgery for PT1B stage. Thank you.
Any questions from the audience? Yeah, go ahead.
So thanks for the presentation. So only I want to highlight two features. One is the difference between countries, because among your patients with an incidental T1B tumors, only 1/3 were detected after cholecystectomy. So in many places, most of the tumors T1B are detected after the cholecystectomy during the pathological specimen exam. And the other thing you already told us is about the high percentage of lymph node involvement. So 21% is a very high percentage of involvement if we compare that rate with the rate of other centers.
Hi, can you hear me?
Yeah, Sonia, go ahead.
Thank you, sir. So, the thing is that we had 11 patients that had undergone upfront surgery and 65 were completion. So, most of our patients were also incidentally detected. The other thing is that all the literature that we have, all these patients have been identified after incidental and followed up as an observation. So, I'm assuming if these patients had nodal disease, they would have been given chemotherapy, and that is not reflected in literature. So we probably miss out on these patients and we do not include them in this cohort. That is why the nodal positivity rate in literature is less.
No, Professor Araxbala's question is that are they really truly T1B positive, T1B, given that they've been sectioned outside, whereas in Chile there are multiple sections, so many of them would pathologically be upstage to T2, which explains the lymph nodal metastasis, right?
You're right.
Yeah.
That is.
Thank you, Sonia. Very good work. Keep it up. Okay. Again, going on the nodal metastasis and the prognosis, now we have a presentation from Dr. Maitham Muslim from United States. So the Western experience, Professor.
Good afternoon. Thank you for the opportunity to present our work. So I will talk today about the factors that impact residual disease and positive margins following definitive oncologic resection in patients with gallbladder cancer. Do I have control of this? Sorry. Yep. I have nothing to disclose. As you must know from the previous speaker, most of gallbladder cancer cases are diagnosed incidentally after laparoscopic or open cholecystectomy for other indications. And in general, the residual disease is found in approximately 60% of those patients, with more than 70% of these cases being a nodal disease or even distant metastases that were discovered later on. The recurrence at 1 year for those patients who had residual disease is estimated to be as high as 40% in 1 year following the initial treatment. As of now, there is recruiting a trial, the OPTN trial, that examining the benefit of doublet chemotherapy using gemcitabine and cisplatin in patients who were discovered incidentally to have gallbladder cancer, receiving this as preoperative treatment prior to surgical or definitive oncologic resection. The aim of our study to detect factors from our retrospective review of our cohort to the predictive demographic and clinical pathological factors that influence the fact of residual disease status following oncologic resection. As I mentioned, this is a retrospective review that we did in our institute between 2012 to 2020. Those patients at our institute had underwent radical definitive resection for gallbladder cancer. We performed a multivariate logistic regression predicting factors that affecting R1 resection following the index procedure that was either oncologic resection or laparoscopic cholecystectomy, and also the demographic and clinical pathological factors that affecting residual disease following the final definitive resection. Most of these patients are referred to us after the fact of its incidental diagnosis, and we have their pathology reviewed at our institution by our own pathologist. Usually 2 pathologists looked at these and they presented at our tumor board. So we reviewed our database and we identified 121 patients, of which 78% patients were excluded. Either they didn't have a follow-up or they didn't underwent most of their treatment at our institute, or the pathology was unavailable to review. And of those, 43 patients had definitive diagnosis of gallbladder cancer. 8 of them had non-incidental disease, and those underwent definitive resection, which are 8 patients, as I mentioned, and the incidental group was 35 patients. So in that index procedure, the outcome that we looked at was how many of those had R1 resection, and of those were 14 patients, which is almost a third of them. Those 35 patients, 33 of them ended up having definitive oncologic resection, including segment 4-5, portal dissection, and those were the outcome that looked at was residual disease. In a brief, the result was on univariate analysis, patients who had pathologic T3 disease had increased risk of R1 resection following the initial procedure. That was 8 out of 11 patients. On a multivariate analysis, taking all these factors, the pathological T3 had the highest statistically significant odd ratio, which is 41 in those patients. So patients with pathological T3 correlates with higher incidence of R1 resection on both univariate and multivariate analysis. When it comes to the definitive oncologic resection, which 33 patients underwent that, the nodal disease was associated with increased residual disease risk, 83%. That was on univariate analysis and also on multivariate analysis. As you can see, the odd ratio was 17. So what that bring importance of dealing with a gallbladder disease as aggressive local disease in this situation, and the benefit of neoadjuvant after the initial diagnosis prior to definitive resection might have some value, especially in patients with R1 disease or nodal disease. I know that current trial is examining this, but this data also support the need of aggressive management of these patients. Thank you so much.
Yes, yes. Come, Philip.
Hello, my name is Philip from the Netherlands, De Reuver. Interesting talk, thanks. Doesn't really surprise me that this is a group you want to give neoadjuvant therapy before the re-resection. But as with the discussion this morning and this discussion, which do you think would be the group you would not give neoadjuvant therapy and go for upfront re-resection? Is there room for such a group of patients, or is your opinion or yours to give them all upfront chemotherapy? As we just saw, even the T1Bs, 20% is node positive.
Thank you for the question. So there are 2 factors that play in this. I would say the performance status of the patient and the biology of the tumor. If you think that patient would have tolerated the old line of treatments, I would say the most important for advanced or locally advanced gallbladder cancer will be the systemic therapy. And that's for T3, I believe, and positive disease. Now, the trial that is going now also examine T2 disease, so we have to keep that in mind. I'm not sure if they're going to do a subgroup analysis for this. Now, if the patient you feel that is not going to tolerate systemic therapy due to performance status, you can go, especially with T1B disease, I think upfront resection is a valid option, taking out the disease and have a better staging of the lymph node locally. Because at the end of the day, the lymph node dissection is not curable by any means, more than a staging process to understand the biology and the local advancement of the disease. We understand that we need at least 3 lymph nodes to do that better dissection. And we've seen in the previous paper they ended up with 10 in the 10 lymph node in the Japanese Japanese experience. But at the end of the day, most of these patients die from systemic disease. So chemotherapy have the upper hand in controlling this disease, especially in patients with good performance status.
Yeah, and now a patient with a poor performance status, so you don't want to give her chemotherapy, but for example, she had primary resection with bowel spill. What would you do? Would that make a difference in your choice?
I think in that situation you will give the patient the benefit of the doubt and go for resection and portal lymph node dissection to make sure you have a better staging and a better discussion about the prognosis of the disease. And the problem with gallbladder cancer, we know the bad mortality, but most of the time we don't know which curve the patient took initially. Was it the stage 3 curve or the stage 1 curve that progressed later to metastatic disease? And knowing that from the get-go, from the beginning, will drive the decision-making down the road. So I'm a believer that lymph node dissection is important for staging purposes, so you know where these patients on the actual curve. Similar to melanoma, when you do the sentinel lymph node, does it drive survival benefit? No, but you know where this patient on the curve, and you have choices to offer. Now we have targeted therapy. We have some studies on immunotherapy when it comes to HPV cancers. Immunotherapy is more tolerable. Targeted therapy is more tolerable. So knowing this patient from staging standpoint is the important factor in managing them. And that's what this surgery offers.
So yes, there are many questions to be answered in this disease, so we'll leave it at that. Thank you very much.
Thank you.
And I think perhaps the next paper throws some light and what is the impact of molecular analysis in gallbladder cancer. Professor Dr. Ekene Emmanuel, thank you for coming all the way from South Africa. I look forward to your presentation.
Thank you so much, sir. So I'm just going to present on a pilot study that we conducting. It's an ongoing study where we try to demonstrate that proteomic analysis can distinguish between gallbladder cancer and gallstone disease in patients of African ancestry. There you go. So I have no conflict of interest. So like we've heard, gallbladder cancer is quite a lethal cancer. It's the 5th most common GIT cancer. It has a poor prognosis. The cases are projected to continue to increase. In South Africa, we've actually seen a sharp increase in cases in the last few years. Unfortunately for us, we actually, in most cases, we diagnose this cancer at advanced stages. And I think this calls for a need for more effective diagnostic strategy. So if you're looking at gallstone disease and gallbladder cancer risk, we know that one of the key risk factors for gallbladder cancer is gallstone disease. In countries like China, approximately 90% of the GBC of the gallbladder cancer cases have an history of GD. Obviously, interestingly, only a few of these cases will develop GBC. In South Africa, we're seeing that, in contrasting to countries like China, we're seeing only about 30% of our GBC cases having gallstone disease. And this is a recent study that we've just concluded in one of our hospitals in Johannesburg, where we looked at 300 patients, and from there, only about 30% had an history of gallbladder cancer and gallstone disease. And we all know that chronic GD, which is gallstone disease, has similar clinical features with gallbladder cancer. So I think the similarity calls for looking for how do we distinguish from these two cases from gallstone disease and gallbladder cancer, and I think that's where proteomics come in. It can be used as a clinical and biological tool. And proteomics is just a tool that you use for profiling proteins, and it can be used to identify biomarkers and help in the understanding of disease mechanisms. And we use the technology called the SWOT mass spectrometry. And I always like using the Mona Lisa as a picture to depict what this method can do actually. So if you're looking at specific proteins, you have targeted analysis. The picture you get is not so clear compared to when you get use a SWAT mass spec. You get less missing information. It's highly accurate. It's highly reproducible. And it's also a very highly sensitive technique. So we use this technology to actually profile proteins to compare between gallstone disease and gallbladder cancer patients. So obviously the aim of our study was to demonstrate the utility of this proteomics technology to distinguish between gallbladder cancer and gallstone disease. So obviously after ethics approval, we recruited some patients. Again, this is a pilot study, so we recruited only 29 gallbladder cancer and 15 gallstone disease patients. We obtained tissues from them, and we did what you call tissue homogenization and protein extraction. And then we went ahead to do a SWAT MS, and we identified the various proteins that are present and unique to these two cases. And we performed a whole lot of stats analysis where we looked at the PCA, the LDA, and some correlation tests. And we also did some pathway analysis to begin to understand some of the molecular mechanisms that might be unique to gallbladder cancer compared to gallstone disease patients. So in some of the demographic data that we found, nothing so much unique amongst these two patients. There was no much differences in the white cell count, for example, or the CRP. CRP had significance. The gallbladder cancer had increased compared to the gallstone disease, and the white cell count was actually more increased in the gallbladder cancer compared to gallstone disease. The age was also quite different, but we did check, and this age didn't have any effect whatsoever in the protein expression profiles. What was interesting again was in our gallstone history of the gallbladder cancer patients, what we found was that even in this 26 patient that we recruited for this analysis, only about 4 of them, 15%, had history of gallstone disease. So we looked at some of the liver function tests, obviously looking at gallbladder cancer versus gallstones. We had some significance in a whole lot of liver function tests comparing gallbladder cancer and gallstone disease patients. So this was the interesting part for us, where we found that compared to gallstone disease patient, our gallbladder cancer had a total of 125 upregulated proteins that were overexpressed compared to gallstone disease, and we also have 106 downregulated proteins in gallbladder cancer patient when you compare it to gallstone disease. And in our top 10 highly upregulated proteins, we had proteins like MYG, SPB, SMC2, CPSM, and then in the downregulated, we had TYRB, RNA-LS2, and AOC3, for example. And so one thing we did was look at, some bioinformatic analysis, look at the pathways in which these up and down regulated proteins are involved in. And we found that, compared to gallstone patients, our gallbladder cancer patient had increased pathways such as the lipid metabolism pathways. They also had increased metabolism of vitamins, of amino acids, for example. They also had increase in neutrophil degranulation. So this is just a bioinformatic analysis of our dysregulated proteins. And if you look at the downregulated pathways, we found that our gallbladder cancer had reduced muscle contraction pathways and also reduction in retinoid metabolism and transport. So for us, we also wanted to look at how do you distinguish between these two groups? Is it possible to distinguish, and how does proteome analysis come to help us in this case? So if you look at the PCA of figure A, we can see that these are all the clinical parameters that we collect for our sample, and we put it into this analysis, and we found that the PCA plot, you can just see that in figure A, that there was no discrimination, it was quite between both groups when you look at clinical parameters alone. At the B, when you look at the B, which has the proteins alone, and in this model, we put only the top 10 upregulated and downregulated proteins, highly regulated, downregulated and highly upregulated proteins. And what you can see there is that there's a bit of distinguishing between the two groups, but it's not as clear as when you look at the C, where we combine both the proteome, both the dysregulated proteins and some of the clinical parameters like the LFT test and inflammatory parameters like WCC and CRP. And I think for this case in the PC analysis, the C, which was a combination of some of those clinical parameters and the top dysregulated proteins, gave us the best kind of discrimination between gallstone disease and gallbladder cancer. We also did an LDA analysis, which is also a statistical test for discrimination. And again, we can see in A, when we put clinical parameters alone, we can see that there's no, the discrimination is quite poor compared to when you combine in the C, you see that there's a real good discrimination between gallstone disease and gallbladder cancer when you combine those specific parameters, clinical parameters, and our upregulated proteins. So basically what we've shown here is that SWOT-MS can, first of all, could help us to distinguish between GBC and GD patient, that this highly dysregulated proteins, that if we are able to identify them in our cohort of patients, when we combine them to certain clinical parameters, they can help us to distinguish between these two groups of patients. And again, I think we try to begin to identify some of the molecular mechanisms, such as the pathways that may be unique to gallbladder cancer patients versus gallstone disease patients. Pathways such as lipid metabolism is highly upregulated. And studies have shown that this pathway can actually aid in the initiation and progression of cancer by inducing cell migration, invasion, and angiogenesis. And again, the decrease in muscle contraction that we found in gallbladder cancer patients could be an early event in the pathogenesis of gallstone formation by causing a decrease in gallbladder motility in vivo. So this is, like I said, this is a pilot study and it's an ongoing study. So what we're doing now is that we've obtained some normal tissues, and we also want to use it as a control sample to actually look at the profiles of normal tissues of gallstone patient and of gallbladder cancer. We also would like to compare, if we have enough samples, patients with a history of gallstones in gallbladder cancer versus those without any history of gallbladder cancer, of gallstones that have gallbladder cancer. I think it will help us begin to understand the molecular mechanism differences between those patients with history and without history. And again, we have an independent cohort of plasma samples, which are about 120 samples altogether. We would like to verify some of our findings going forward. Thank you.
Thank you, Emmanuel. It's very interesting to see a geographical variation. Like in Chile, literally every patient has gallstone disease, and you have 30% without gallstones.
So in your country, among the patients with gallbladder cancer, what is the percentage of gallstones?
So that's what we just said. So it's about, there's a retrospective study that was just completed by Dr. Devar in our department. So we just found about 30%, approximately 30%, out of 300 patients has a history of gallstone disease.
No, 30% only have gallstones.
Yes, has a history. Versus,
So very low percentage.
Very low percentage.
Do what?
Very low percentage compared with other countries, 30%.
Yeah, so only about 30% has a history of gallstone disease.
Yes,
Yeah.
Yeah, go ahead.
Hello, my name is Daan Komes. I'm a PhD student from the Netherlands. Nice presentations first. I was wondering, what is the ratio of patients with uncomplicated symptomatic gallstone disease and complicated gallstone disease in your study?
I don't think we had a look at that if they were completed or uncompleted gallstones. So
and why not?
I think that that's probably something that we should look at. Like I said, this was a pilot study, and I think going forward we can look at the differences and see if there are. But we didn't look at the differences in this study for now. But I think it's something that we can actually look to.
Yeah.
That would be interesting to see.
Nice. Okay, thanks.
Thanks.
Thank you.
Good question.
Emmanuel, I think, gallstone disease and gallbladder cancer are two different diseases.
Yes.
But this is something which is interesting. If you compare gallbladder cancer with and without history of stones,
that will be interesting.
That will be interesting, rather than gallstones versus gallbladder cancer.
Yes.
So I think these studies, and in the gallbladder stones, you have plasma samples which can predict in some way. That's the question which the young gentleman, thank you very much for your question, is asking that, can I identify a set of gallstone disease which are at a high risk for gallbladder cancer. So the follow program can be, so both these ongoing studies are very important.
Yeah. So like I said, this one I just presented was just to demonstrate how the importance of
Proteomics is
SWOT MS can be used to help
absolutely.
us to see. Obviously, like you said, the important aspects will be looking at things like, without history, and
Yeah, please continue your excellent study. Thank you very much.
Thank you.
Well, the last presentation for today is not gallbladder cancer. It's by Dr. Urase Staten as intrahepatic cholangiocarcinoma. Does lymph node dissection affect survival?
All the way from Thailand, welcome.
Yes. The theory presentation is the intrahepatic cholangiocarcinoma. Does lymph node dissection affect the survival? I have no any disclosure. Intrahepatic cholangiocarcinoma is the common cancer in the northeastern Thailand. The incidence of the cholangiocarcinoma in our region is up to 85 per 100,000 per person per year, which is the highest in the world. The surgical resection is the cornerstone treatment for this disease, and lymph node dissection is still controversial. The aiming of study is to investigate the survival benefit for the lymph node dissection for intrahepatic cholangiocarcinoma. We retrospectively review intrahepatic cholangiocarcinoma who underwent laparotomy from October 2013 to December 2018 at Sipasong Hospital, Ubaraj Thani, Thailand. There are 407 patients. 101 patients were unresectable, and 306 patients were surgical resected. Of this, 64 patients were excluded due to the palliative resection and pathological proven metastasis. 242 patients were curative intent resection. In the curative intent resection, there are 69 patients that not received the lymph node dissection groups, and 173 patients who received the lymph node dissection. The lymph node dissection positive ratio is 49.1%. The baseline characteristic between the lymph node dissection group and non-lymph node dissection group were different. The first factor is the type of the resections. Second is the resection margin. As you see in this table, the non-lymph node dissection have achieved more zero resection. Also, there were tumor size and perineal invasion. In the lymph node dissection group, the tumor size tend to be larger and have more perineal invasions. Also, the T staging are higher in the lymph node dissection groups. On the survival analysis, the median survival time in the lymph node dissection group is 14.6 months and 15.8 months in the non-dissection groups. On the multivariate analysis, we adjust the confounding factor that I mentioned above, which include the type of operations, tumor size, and perineal variations that are different between the two groups. As you see in the cost proportional hazard regressions, the hazard ratio is 0.695, and the p-value is 0.113. As you see, the graph, the lymph node dissection group have tend to be better survival, but not statistically significant. We further divide the patient in the lymph node dissection group into, according to their pathological status, the lymph node positive and lymph node negative. The multivariate analysis showing that the lymph node negative group have comparing to the three groups, they have the best overall survival, with the hazard ratio is 0.46 comparing to the non-dissection group. And in the lymph node positive group, the survival is as the same as the non-dissection group, with the hazard ratio at 1.06. In the previous study, there were conflicting results. The statistical math study from the Mr. Kim in 2019, there was a better overall survival in the lymph node dissection group comparing to the non-lymph node dissection group, with the median survival time is 90 months versus 44 months. And on the systematic review by Dr. Cho in 2018, there was no significant in overall survival benefit. With the hazard ratio is 1.13, and the p-value is 0.2. In the conclusion, lymph node dissection appeared to demonstrate the two-stage in which overall survival is better in the lymph node negative groups. Interestingly, the overall survival in the non-dissection group was not different from the lymph node positive group, and there was a better overall survival trend toward the lymph node dissection group comparing with the non-dissection group, but not statistically significant. Thank you.
In intrahepatic cholangiocarcinoma, which is resectable, would you do lymphadenectomy as a standard procedure?
From the data, I will suggest.
Yeah, you would do it.
Yeah.
If the nodes are positive preoperatively, would you go ahead with resection or would you not go ahead with resection?
From the preoperative imaging,
yeah.
If there is any, if the lymph node positive group are in the regional regional lymph node, I will go for the lymph node resection.
Excellent, thank you.
Okay.
Bye. Thank you very much, all the presenters from here and outside. And we close the session. Have a nice cup of coffee in the exhibit hall. Yeah.
Ellos exigían antes que se le pusieran vasos de plástico, ¿ves? Ahora ya no han dicho nada, pero mira que se usan los vasos, ¿ves? No toman el agua.